Okay, thank you all for joining us today. I'm going to go ahead and get started since I know we're just a couple minutes past noon. My name is Heidi Moorfield. I'm a postdoc in the Global Health Program here at Princeton. I recognize many of your names in the participant list, so thank you all for being here. And it's my pleasure today to introduce you to Dr. Kimberly Sue. Dr. Sue is the medical director of the Harm Reduction Coalition, a national advocacy and capacity building organization that promotes the health and dignity of people and communities impacted by drug use and the racialized response to it, the war on drugs. She holds a double degree from Harvard Medical School's Social Science MD PhD track. Her PhD work in sociocultural or medical anthropology explored the intersection of US prison systems, addiction policy, mental health and drug treatment, and resulted in the publication in 2019 of the book Getting Wrecked: Women, Incarceration, and the American Opioid Crisis, published by the University of California Press. Dr. Sue's medical training at Massachusetts General Hospital in Boston in internal medicine and primary care focused on substance use disorders and addiction medicine. She currently tends to patients in syringe service programs. She is also an attending physician at Rikers Island Correctional Health Services, doing primary care, chronic disease management, HIV, STIs, substance use disorders, and transgender care with incarcerated patients. Dr. Sue's work draws attention to how structural violence, oppression, and stigma operate in medicine and healthcare settings and how they harm the health and well-being of people who use drugs. According to Dr. Sue herself, she believes in centering the expertise and knowledge of people who use drugs, engage in sex work, and experience stigma in many other ways. Dr. Sue also worked in Tanzania and South Africa and has published her work in academic journals such as Medical Anthropology Theory and the AMA Journal of Ethics. So I'd like you to join me in welcoming Dr. Sue today for her talk, which is titled Getting Wrecked: Harm Reduction, Substance Use, and the COVID-19 Pandemic. And just a brief note, we are trying out the closed captioning feature on Zoom today for the first time. So we're hoping that it will be mostly accurate. It may mess up here or there, but I'm hoping that it'll be helpful to you. So if you need to enable that, there's a button, or there should be a button at the bottom of your screen. So thank you, Dr. Sue, for being here.
Thank you so much for inviting me, Heidi. And I'm just going to try to share my screen. So let me know if this works. Can you see my slides? Yes, okay. So in the interim, my bio has updated. I've moved to Yale, where I'm an instructor in the program in addiction medicine. And so I see patients at the primary care methadone clinic, and I also attend on the addiction consult service, and I'm starting my research back up. So I also remain the medical director of the National Harm Reduction Coalition. So I was spending a lot of time thinking about this talk, and I was like, oh wow, I wonder if I should give them my book talk, which I've been giving kind of intermittently, because of the pandemic over Zoom, but I did want to update it to reflect a lot of the experiences of people who use drugs in this last year, as well as my response as a doctor and the kinds of care that I gave and continue to give in 2020, and reflecting a little bit on both kind of themes from my book, but also ways in which the pandemic has worsened structural violence for people who use drugs. So it does kind of incorporate a lot of my current thinking and thoughts. So if you don't know about National Harm Reduction Coalition, we are a national organization that does a variety of different technical assistance, overdose prevention, policy, and advocacy. I've been involved in some recent policy work with the change in the administration with Biden. So it's been very exciting. I also provide technical assistance to other doctors and organizations around the country to improve the care of people who use drugs. And my expertise is really on medication for opioid use disorder in prisons and jails and how to implement that. So I have no disclosures or conflicts of interest to declare. So I'll start the talk by just giving you a little bit of information about what happened last year. In December, CDC put out a health advisory network that really showed that we're going in the wrong direction. So we are seeing basically an increase in overdose deaths. We have not seen a plateau. We have not seen it go down. We've just seen a steady increase in overdose deaths. And it actually captures some COVID time as well. So it goes up to May 2020. And all indicators suggest that even after May 2020, we around the country, we were universally doing worse. And so what I'll argue here is that we really need to take a look at what we're currently doing, at the policies that we currently have, and really we need new approaches and fresh eyes to this problem, because we have not effectively been saving lives and improving the quality and the well-being of the lives of people who use drugs. You can see that really this also breaks it down by category of substance, and so all drugs, synthetic opioids, cocaine, and when they say psychostimulants, it really is a reference to methamphetamine. They're all up. Okay, so that's pretty important as well. I think it's also hard. A lot of people are not as aware of cocaine and stimulants, but we're really seeing a rise in stimulant-related deaths. This is another slide from the Health Advisory Network that just shows an increase in fatal overdoses with all substances and what states those are in. So harm reduction is both a philosophy and a practice. So we can think about it as a philosophy and orientation to improve the lives of people who use drugs, an orientation against oppression and structural violence, against structural racism. So that's kind of a philosophical approach, but there's also a practical approach that has to do with specific interventions. And people may have heard of syringe access or syringe exchange programs. That's definitely part of harm reduction. We also see expanding access to naloxone, which is a medication used to prevent an opioid overdose or to reverse one, a fatal opioid overdose, as a part of a harm reduction service. But we also consider all of these other components as well, including safer drug use. So ways that we can help people use more safely, ways that we can, for example, this cartoon is really people engaging in drug checking, for example, or drug checking technology to make sure that there's no fentanyl in their substance if they don't want fentanyl to be there. We also have supervised consumption services or overdose prevention centers, which are places that people could go. In theory, there's over 100 around the world, but none that are above ground in the US, where people go to use drugs and receive naloxone, receive overdose response, receive care. We have a big problem in this country of people using alone and dying alone at home. That's happened to several of my patients in Boston. And housing first even, so programs that say like, there's no condition for you to have housing, even if you're using substances, and or especially if you're using substances. Like many people, for example, might use meth like to stay awake in a park to avoid being raped. Like there are reasons why people use substances that have to do with housing. And even just drop-in centers, so places where people can have a shower, have food, get some respite, and even places where people can just be or use substances and not be sort of suspect to the surveillance mechanisms of a police state. I think of drug use as a continuum, and this is how I talk about it with my patients, and this is how I talk about it with students, but really you can look at a substance use by substance as a spectrum that can range over the course of someone's life and over the course of time, and there can be goals. And I work with my patients on trying to understand where they are in relationship to their substance use and where they want to be. And a lot of people, for example, that are, have alcohol use disorder, maybe I may see in the hospital for liver failure, and they say, I don't think I can like stop. I just want to be the kind of person that can have a beer at, the football game and have a glass of wine at Christmas. And so they really want to be a social drinker. That's their goal. And so, that really is a benefit, honestly, for them to move from a place of hospitalization or chaotic, persistent, debilitating use to a social use. And if that's their goal, then I try to get them there. It's very contrary to what most healthcare workers and doctors in this country want to do, which is we've been taught and told that everyone should be abstinent, which really is not the case. We do know that most people use psychoactive substances, and we don't have a discourse for talking about it. So this is my book that came out in 2019, and it was the product of my dissertation research on women in Massachusetts. So I explored the critical question that I address in the book, or in my dissertation as well, was so much of American criminal policy or addiction policy is to incarcerate. And if that's the case, then what actually happens when people go inside? And actually, because I was a medical student at the time, I had much easier time getting access to these carceral spaces than I probably would have otherwise. So I did a multi-sided ethnography, which included a community-based cohort out of a heroin treatment program called OBOT, or outpatient buprenorphine opioid treatment in Jamaica Plain in a community hospital run by the state. I recruited women from there. I also recruited women from the local jail and also women from the local prison. So I did kind of follow the women in jail and prison through their, quote, treatment experience. And then I followed them when they left. And I write about it in the book. And it's been very interesting to talk to people about this book and think about the ways in which we can use ethnography to change policy, the way we can use ethnography to change people's perspectives. People's perspectives towards drug use in this country are very entrenched, ingrained, that it's substance use is a moral failing, that it's a sin. And even looking at regular discourse about drugs, or, oh, that person looks like he's on drugs, or this person's on drugs, or this person was on drugs. And it's really disheartening, honestly, because we all use substances. So the way in many ways, it's an uphill battle every day to have some coherent and compassionate discourse about it. I also started a podcast at Harm Reduction Coalition, which on low barrier access to buprenorphine, which is an opioid treatment that I provide. And one of my patients talks about her experiences getting access to treatment and meeting me in the syringe exchange and what it's like there. So I try to use narrative in a way that can both be empowering and really help people understand the big issues. I also took Loretta to Columbia Medical School to give a lecture to the first year medical students as a centering the expertise of people who use drugs and people who are in treatment, because she has so much more experience than I do. So we also have been seeing, so despite the, so some interesting confluence of problems in this past year that have been building on the structural inequities I talk about in this book in interesting ways, including significant increases in substance use. So we're just seeing everything, we're backsliding everywhere. Tenuous gains that people have made in certain areas have been lost. Health department staff have been shuttered. They've been moved in New York State. They were moved exclusively over to COVID testing for the entire past year, which was the Office of Drug User Health that I worked with very closely. They're actually still like out in field sites doing COVID vaccination. So they've been pulled entirely out of substance use as their main area of expertise and focus into vaccinations and to COVID. I'm not saying it's wrong, but it's quite crippling. We're seeing increases in substance use, alcohol among women, people under 40, increases in mental health exacerbations, and really isolation. We're seeing now, although maybe things are turning around, but we just have been seeing a lot of people whose traditional ways that they access community have been disrupted. Many of my patients at the syringe exchange, they used to come down and like hang out all day. And now they have nowhere to go and they have nowhere to be. And if they use, they might use and die alone. And it's pretty horrific. On top of that, we have a toxic street supply of substances, which includes fentanyl. So throughout the pandemic too, there has been an interesting, there's been a lot of interesting ways in which stigma against people who use drugs and against people experiencing homelessness have really come to the fore. And this is an article from the New York Times, which is like the ugly side of New York's outdoor dining renaissance, which we can talk about. Some restaurants were really claiming that, people who were using were, preventing their businesses and people who were experiencing homelessness. So those are kind of old tropes, and they get brought. Actually, Trump played on it very much as well. Was sort of this law and order rhetoric, a white flight, suburban rhetoric. Very othering. It's quite damaging. This is also stuff that came out of that period, and I was involved in a lawsuit actually around this, helping the hotel. So there was a hotel on the Upper West Side that basically was contracted with the city to house people that were homeless. This happened in a lot of cities where for COVID hotels, for people to have places to go and avoid congregate shelters, which we knew were places that we were worried could spread COVID. So one of the hotels on the Upper West Side, there was a big Facebook group that got like hundreds of thousands of Upper West Side residents involved in kind of not in my backyard things. And then a counter protest came up, which was called Love on the Upper West Side, or and so they protested and they actually organized a law firm to defend the residents of that hotel, that they should be able to stay there. The mayor actually tried to move them, and a reporter asked me, so they want to move them to like a hotel where they basically would have to go through a bar to get into their hotel. Like, how is that? And I was like, well, that's actually can be very problematic for many people. So a lot of people had wanted to stay there and they felt settled there, and they were accessing services in that area. So it made a lot of sense for them to stay instead of being, if you've ever met any patients who experience homelessness, one of mine has been shuttled in numerous boroughs for 2 years, and she's still without permanent housing. She's in a domestic violence shelter. She was last year was shuttled to a borough, Brooklyn, which is not her safe borough, and that's where her abuser lives. And she was actually crying when she called me up one day because she was in her not in her safe borough. She'd been moved. So it's very traumatic for people to be shuttled around like that, as you can imagine. So I guess I do. Some other thoughts are, again, even though I'm a doctor, I've been trying to move away from this medicalization framework, and I'd love to hear your thoughts on it, because everyone always presents medicine and public health as the kind and gentler arm versus criminalization, and I understand why that is. But it also is simply a matter of human rights. And I think that framework exists internationally, but often gets eclipsed in the US, and we don't really talk about like human rights paradigms as we talk about in other places. And I think it's really important to bring that into the picture. because it's really not just a medical or public health issue. It's really just like a decency, a dignity, and a right to safety and well-being framework. So a lot of the work that I'm trying to do is move outside of the clinic. And as I talk about in my book, I hope that these are, we can think about interventions and ways to engage people that are outside of the clinic. I hope that we can really work with people who use drugs in their own activism and advocacy and pay them, and that we can work upstream in these areas of explicit and, really deeply encoded structural violence and racism. This is as well, again, the past year has illuminated for me and for many people how deeply racialized our response to substance use is. And there's been a clamor of people saying that, Black people and Black drug users' lives matter. The War on Drugs, Drug Policy Alliance just put out a briefing about Breonna Taylor and how the war on drugs had a hand in killing her, essentially, with the no-knock warrants that were allowed because of the war on drugs. And George Floyd as well had substances in his system, and Derek Chauvin, who is going to trial. I spoke to the Washington Post about this last week or over the weekend. Derek Chauvin's defense was saying that George Floyd died of a fentanyl overdose. He had fentanyl, methamphetamine, cannabis in his blood. So I spoke to them about what a fentanyl overdose looks like, which is really not what we see in the video. And these are ways in which they erode people's humanity and people's right to life. And it's quite insidious and baked into our legal system. It's baked into our cultural ethos, and it's very, very dangerous. There's also ways in which we do this for people who are incarcerated, where we say, oh, there's Daniel Sarad wrote a book called Until We Reckon, and it actually talks very, very eloquently about quote unquote, the false dichotomy of non-violent versus violent offenders, and really how that paradigm creates more danger for people who have been accused of quote unquote violent crimes. And really we can't pit those groups of people against each other when they're all experiencing numerous axes of structural violence. So I'll just end with a couple practical frameworks that I use when I work with people who use drugs. And I'm not sure where you guys are at in your training or your education, but this is what I use with patients, which is build a safety plan. This is from New York State Department of Health. And really, these are just practical things to do so people can, use more safely, use with education, that we don't tell them to stop, and that we can really help them achieve their health goals and help them live and thrive. Harm Reduction Coalition has put out a bunch of material and guidance. We started to put this material out last March. I have some flashbacks to it, where people were asking me a lot of questions. I was like, I have no idea. This is a totally new entity I've never encountered in my life, and no one has. And people were asking me questions like, if you're homeless and you're living in, this place, and you shower in the bathroom and you use one of those hand washers, like those big blow dryers, to will that spread COVID? How I'm doing sex work, what can I kiss? And all these other things. And we really didn't know at the time. I was just guessing. And so a lot of this guidance was just common sense. A lot of it was based on what we thought might make sense, but included things like not using alone. It included things like getting enough drugs. People were worried that they were not going to be able to go out, that their supply would be depleted. We actually were really worried that people were going to reuse syringes over and over again or share them, which is definitely harmful for risks of HIV, hepatitis C, and abscesses, soft tissue infections. So we were very concerned about that. We were actually looking up and representing stuff from the Centers for Disease Control on how to bleach your syringes, which goes back to the HIV epidemic. Really, really concerned about people. And also concerned that if people went out, that they would be arrested if they went out to get drugs. So people were saying things like, carry a bag of groceries and just say you are going out for essentials and try to protect yourself, because we have to think about protecting people overall from the harms that exist in their lives, this everyday structural violence. So those are some of the things that we've done, and I'm happy I left. I'm going to leave some time just because I think it would be great to have more of a discussion with you all. I've also, in the past year, I also did COVID work in one of the makeshift hospitals in New York City in Queens. So I did that for about 2 months near LaGuardia in actually Corona, Queens, ironically. So I did that for about 2 months. I also became the temporary medical director of a methadone clinic in Canarsie in Brooklyn. And one of the staff died of COVID. So I became like emergency credentialed to do that. And at the same time, I moved all of my patients at the syringe exchange into telehealth. So I did telebuprenorphine for their heroin or opioid use disorder. And now I'm at Yale. So I don't know if you guys have any questions, but I will stop and we can chat. Thank you.
Thank you so much, Dr. Sue. And so we will be taking questions via the Q&A function. So this is a webinar. You should see a Q&A button down along the bottom edge of your Zoom window, and you can submit questions through that. And Arbel and I will help to moderate the Q&A.
Yes, maybe we can start with, I have a question. So while we collect other questions, I'll get started. So thank you so much, Dr. Sue, for this. This is so interesting, and there is so much to think about. And one thing that I really like that you said is about this move away from the framework of medicalization and your embrace of the human rights framework and perspective. And I think it's really interesting. And I was thinking about another idea of a continuum, or a chronic condition, maybe. So some authors, such as Joe Domet, talk about health as more and more a process of chronicity. And I think I just wanted to hear you more about this idea of a continuum, and that being maybe more helpful to work with, but also if there is any kind of goal or perspective we should have in thinking, of other places people can move on to beyond the continuum.
So beyond the continuum
of drug use, I think you said that you deal with this problem as a continuum, right? It's not something, if I understood it right, that is going to start and end, with, I don't know, or you shouldn't expect it to be that, or you shouldn't deal with it this way, if I got it right. So right. Yeah, I would like to hear you more about this, about chronicity, health and chronicity, about this continuum in dealing with drug use, and also what we can imagine as an otherwise.
I mean, it's an interesting point. Really, most substance use doesn't even hit the surface of being clinical, honestly. And most people lie to doctors. I myself have lied to doctors because of those significant collateral consequences that have to do with your employment, that have to do with discrimination, that have to do with et cetera. For doctors, for example, to disclose mental health or substance use issues, it goes to like your state licensing boards. Like those are things that really are hard to recover from. I was just I was credentialed here at Yale, and I was doing some paperwork for the methadone clinic, and they were like, I was really hating this, but it was like, you know, you have to account for in medicine, you have to account for every single month that you ever like had. And if you like don't have a month accounted for, they assume that it's because you were, you know, had some mental health crisis. It's this encoded stigma. Like if you went on vacation or you went somewhere for 3 months, like it all has to be accounted for, which is really disturbing. Obviously, the kind of you know, it's really problematic. I think so. Most substance use is really not problematic. It doesn't even reach the surface. We know that people use for so many reasons that and if people kind of have the privacy and the ability to use substances, they do, and they like to use them like they want. Most people, you know, people, you know, so the majority of that doesn't even reach us. But really, when we talk about it, it's always encoded as like a in dominant discourse. It just doesn't even, it doesn't get talked about, and it doesn't get talked about as people being functional. And there's a professor at University of Washington, Ingrid Walker, and Carl Hart at Columbia, and they basically say like people have to come out of the closet. People with privilege have to come out of the closet, because what ends up happening is we have this these narratives that get codified and reified as criminals, as you know, people that are like wretched, you know, as like everyone is, you know, chaotic. And that's really simply not true. And and so I really do think that that is actually quite important. I think as a continuum, I mean, it's also interesting. It doesn't account for people's sort of like a socio-spatial thing as well, for like where people are. So drug set and setting. So is a common framework that we've used in addiction, and really thinking about, so the drug, the set, which is kind of the mindset, and the setting, and all of those have to do with people's experiences of substances, and that can change over time, and that's, you know, that can make things good or bad for people, and that can change as well. So I think, you know, thinking about everything as a continuum where someone is like, it's much more complicated. And then people are also, we know that polysubstance use is the norm. So you see kind of a linear thing, but like people are grabbing like people are doing 4 things at once, or people then do this thing. And so really that like diagram can't really account for the complexity of what people are actually doing and the ways people are experiencing it. So I think that social scientists are really interested in that, and understanding people's, you know, experience, their experiences, you know, like Walter Benjamin. Everyone's very interested in like the inner experience as well, and what does that say about substances and their hold on us, so across all societies and across time.
Thank you so much, Dr. Sue. And I think we had a hand raised from Syed, and I think Anthony's able to let you unmute if you still have a question, Syed.
I think they're no longer here. I did look for them, but this is good to know. But if they are, please let us know. And we have some questions also in the Q&A.
He's back, I think. There we go.
Oh, okay.
Hello, everyone. Wonderful presentation. Just a quick question. So I'm actually, I joined this call. I'm in Karachi, Pakistan, and just wanted to ask, so the substance, I'm a substance abuse counselor with a drug rehab center, one of the largest ones here in this part of the world. We didn't have the same issues regarding the outcomes that were shown in this presentation. And I'm curious, why is there such a disparity? I mean, I would say coming from a developing economy the stressors, the lack of resources, availability of resources. Life, I would say, is a lot harder in this uh, part, part of the world, in this country, Pakistan, compared to what I perceive the availability of resources, government support, compared to what we have, or what the support that was given to us during this whole pandemic. I mean, I find it a bit strange, the outcomes of such rampant rise in substance abuse. I would have thought, we would be having these issues, but can you give some insights into this?
I mean, it's hard to, yeah, thank you for that question. It's hard for me to weigh in, these would just be guesses, based on, kind of in a comparative experience. I think it's obviously a much more complex phenomenon than simply having access to, government resources or having a stronger economy. Really, I think trying to understand trends in substance use, trying to understand, it could have something to do with accessibility of substances here. It could have something to do with, there was a lot of concern, for example, that some of the increases in alcohol use really were because we had all of these alcohol delivery systems that would just bring alcohol, courier alcohol. Someone would drive alcohol to your door and you didn't really have to go anywhere. So a lot of people were able to access substances. And really, I think, but for, something that was actually an interesting point was also that when COVID hit, initially there were a lot of people who were like, this doesn't affect the everyday structural violence of my life, being homeless and using drugs anyways. COVID does not affect me in those ways. And so I think thinking about the ways, thinking about the support networks that people have, thinking about the communities that people have, thinking about what people were drawing on as resources and throughout COVID is really interesting. We also saw a lot of increases in gun violence. Rikers Island, for example, where I used to see patients, they decarcerated throughout the pandemic. So they released a lot of people out of jail. And now they have a higher level than pre-COVID because of kind of the economic stress that people have been under. They're now reincarcerating at a higher rate than ever before. And so these are things that also are going to play out over a longer term. And we're probably going to continue to see the impacts play out of kind of the entrenched lack of access to housing, the evictions that are coming. There's a lot of things that we're worried about. And I think it also speaks to the fact that many people were tenuous and kind of back, and maybe they were just managing to get by and just hanging on, and then they really backslid. But it's an interesting question.
Thank you so much. We have a question in the Q&A from Andrew Wu, who writes, how do you build trust with patients to encourage use of the various services the coalition offers when many of them have been subjected to structural violence? Also, may you please explain more about changing the mindset of policymakers and healthcare workers regarding addiction? How do you approach that type of outreach?
Okay. Okay, so this question of building trust with people who use drugs who've been harmed by structural violence is it's incredibly difficult, and honestly, it's really one of the biggest problems that I've faced in the last 5 years or so, which is we can offer compassion, you can offer resources. But for example, I had a patient who was really chaotically using drugs, and she'd been stigmatized in the emergency room. She was called a junkie. I mean, she was called really a language where she was blamed for her conditions. They couldn't find a vein, so she was really abused. She literally felt terrible. And she's like, and I hear every day from people saying things like, I'd rather die than go to the emergency room. Like, I have this big black breast mass in Oklahoma. I'd rather die. If I go, my kids will get taken away. I'm sorry, that's my dog. Sorry, hold on one second. Okay. So it's okay. It's okay. Come here. Come here. Come here. Come here. My dog is just hey, it's okay. Come here. Can say hi to everyone. Okay. Poppy, say hi to everybody. She just woke up from a nap. So it's impossible. And I would say, like, well, come in and, but I can't guarantee that the nurses, I can't guarantee that the front desk, I can't guarantee that other doctors, I can't guarantee that anyone is going to treat people with dignity and respect. I can't guarantee that everyone around the clock on all their shifts is going to do that. And because of the way our brains work, people have been negatively imprinted with those experiences where they're like, they don't remember when people have been compassionate to them, because we have, people definitely have been, but they remember those times when they were treated like they were pieces of shit, or, to use their language. And it really takes a lot of patience. It takes a lot. And oftentimes I say to people, there's no reason why you should trust me. People come in, for example, and when I do trainings for other doctors, there's people who come in with a rash, and then someone's like, oh, or like mouth pain or something, and they have like track marks from injecting, and other people want to talk about it, that they just want their rash taken care of. Like, they don't want to talk, so there's a lot of ways that we can actually listen to people and give them what they want and need, and try to build relationships. As an anthropologist and as a physician and in primary care, I really am interested in getting to know people and, just building those relationships and walking with people. It takes a lot of time. And sometimes I even say to people explicitly, like, there's no reason why you necessarily should trust me. And there's other doctors. I do try to there's a Harm Reduction Coalition manual we made called Quality Healthcare is Your Right for people who use drugs, where we talk about like kind of patients, like rights, and like how to best interact with doctors to get a like a satisfying encounter for them and to get what they need. So it is literally something I think about all the time, and it's especially when I'm training. So I'm training the addiction fellows or the residents or the med students in the hospital, and how do you teach and model that compassion and that dignity despite all of the structural harm. So it's really, sometimes it's getting things like going the extra mile, like getting people what they need. Like, I'm in the hospital, but on discharge, can we offer you 10 or 20 sterile syringes? Like, what do you need? And so and people are so surprised that like you would extend yourself to do that and recognize it, kind of the power dynamic there. And how to change the minds about policy makers and healthcare workers about addiction. So we're very excited at Harm Reduction Coalition because $30 million was appropriated for harm reduction in the rescue plan, in Biden's rescue plan. That's the first time like we've had explicit funding lines really in like a while or ever. And really, I think it's simple, but it's not so simple. First of all, I think talking about evidence and evidence-based approaches is important. Taking a human rights perspective and a compassionate approach, because what I've consistently said over the last year is like, what we are doing, and what I said in the beginning of this talk is, what we are doing is not working. Can we like agree on the fact that more people are dying every year, that we're going backwards, not forwards, that things are getting worse and not better? Can we like agree on some set of facts, which isn't always the case, that we can agree on a set of facts in this country. But I do think that you know, it can be humanizing, for example, for people to talk about their family members and the ways they've been affected. The last Surgeon General, Jerome Adams, would talk about his brother who was incarcerated and had a substance use disorder, and how that helped him change his mind in Indiana about a syringe exchange there. So we can use like kind of testimony as well. I think, you know, again, I just present the facts, like what we're doing isn't working. We need to innovate. Like we do know, again, it's like very hard to think about long-term policy when everything's very short-sighted, but I kind of do my best.
Yes, thank you. I see you can read the questions as well, but we will read them out loud. So there is a question for an anonymous attendee, which is, I don't understand exactly, because in my list of participants, everyone has a name. So if you just want to state your name, raise your hand maybe and say your name, but I'll go ahead and read it meanwhile. What has your patient's experiences of medication-assisted treatment looked like during the transition to telehealth? Have there been issues of access to other barriers that arose?
So that's a wonderful question. I would love to hear their experiences of telehealth matching up with mine. Some of them have loved it. Some of them have been like, why would I ever go to the doctor and like wait and have a copay? And they actually don't have a copay at the syringe exchange because we see them for free on grant money, but like most people have copays, most people have to wait because I'm running late or everyone's running late and do urine toxicology. Like there's often this whole rigmarole, and many patients felt truly liberated. And I saw a patient on the video who was in opioid withdrawal, vomiting. He was like, wow, it was on FaceTime. We were like, it was really like, I would not want to have wanted to be there in person. That was like in May. He was in the Bronx. I was in Brooklyn, like, which is like leagues away. Like we would never, like it would have taken us, you know, a lot for him to have met me in my clinic in Chinatown in the syringe exchange. And so I stabilized him. I got him medication at his pharmacy. It really is completely a game changer. It's completely disruptive. It can really innovate. I mean, it really was like eliminating a lot of this, the traditional doctor-patient visit. I mean, it really was liberating for both of us because I could do it at home. I wrote a piece for Somatosphere where I was like, I'm at home. I let her, you know, which is amazing. And I'm so burnt out and all these other things. And so it was like really wonderful for me as a provider. As the time went on, many of my patients were like, I need to see you. Like people, what is it about the encounter itself that was, it started to be less novel, and people were like, I miss coming, because I would go to group right after your thing. I'd go to my group and like, I miss the accountability of giving a urine. I mean, I want you to show you how good I'm doing with these, you know, because we weren't checking urine toxicology. I'm just giving your medication. And so people were really like lost kind of what structures had hooked them into like a daily schedule. Many patients actually like traveling on the subway and like getting out of their neighborhood and going to giving them some daily structuring quality to the nature of their day and their lives. That was gone, you know, so these kind of hold us psychologically in place. Like if we had been going to a place to work, we weren't doing that anymore. It all fell out. So that actually, so we were like, wow, it's amazing to liberate these medications. You really don't have to like gatekeep them and police them as much as we always have done, which is wonderful. But at the same time, some people started to have difficulty and access issues. So minutes, people didn't have phones. Some people had to like come to the shelter to get access to a phone. There were some patients who wanted to start treatment. They didn't have a phone. So everything was really being done by the phone. So there were a lot of people who didn't know how to use a phone. Or if we were doing telehealth, I did try to do like a video app with a waiting room for some of my patients. None of them could do it. None of them could get in the waiting room. Literally, I would sit in that waiting room and no one would show up, and I'd have to call them on the phone. So there was just a lot of health, navigating these healthcare systems that was really quite difficult. So ultimately, it ended up being mostly just telephone being the easiest. But I did encounter one patient one time who was deaf. I mean, there were a lot of barriers, definitely a lot of barriers. But I do think in some ways it can be liberating. For example, there were ways we were thinking about access for rural health for the Indian reservations, where it's like I could just treat like 300 patients like in upstate New York that don't have a doctor who does this medication immediately without even going up there. I mean, it could really solve a lot of our deep structural access issues, telehealth, for a lot of different conditions.
Thank you so much. I realize we only have a few minutes left, so I'm going to read actually both of the last questions, and then if you have just any thoughts, Dr. Sue, I'm not sure you have to answer them as maybe in depth as the others, but Nikhil Pandey writes, thank you so much, Dr. Sue, for your illuminating talk. I'm a grad student in anthropology at Princeton and work with low-income opioid and heroin users in northern India. Something that I've encountered in my ethnographies recently is the way in which stigma of COVID-19 and of being a substance user is overlapping in curious ways. Some of my low-income interlocutors tells me that the stigma of using drugs is so tremendous that they'd rather have COVID-19, presumably to deflect the stigma of substance use. This, as you can imagine, stigmatizes them only further. In light of this paradox of sorts, I'd like to invite you to talk more about this process of stigmatization. How can our public health approaches and how we react to them as ethico-moral community be reconfigured in your view? And then another attendee wrote, thank you for your vital work. I hope to do more, I hope more and more places adopt your stance and the work that you do. From your experiences, do you have any insight on primary prevention of addiction? In other words, keeping folks on the left side of the continuum, which is social use, and preventing use from moving into addiction.
Great, so I'll kind of take them as one. So again, this has to do with, both have to do with predominant cultural mores and like deep historical trends. Prevention, for example, we know that what protects people isn't necessarily educate. There's kind of been these approaches that have been like, oh, like, what is it that makes, like, is educating people about substances and telling them not to use them, like, that's how we've been, like, have we actually educated people about substances in this country? Like, no. Has it stopped them from trying them? No. Has it stopped some people from chaotic use? No. 50% of substance use disorders is genetic. I say that right off the bat because so many people believe it's a moral failing. And so I'm like, you were dealt this hand in life. This is your, this is your cards, and we have to figure out how we can like get you, the best outcome. And that is kind of destigmatizing, honestly, because like especially for people who are using, they feel so, there's so much blame and shame. But I do think the protective factors, and just thinking about resilience and thinking about community and thinking about ways in which people, so thinking about structural violence and structural vulnerability and things that actually keep people, whether it's family, whether it's education, these are kind of clear pathways out of poverty, addressing trauma, without substance use, access to mental health services. There's so many people who'll be like, I started using because my son was shot in front of my eyes in the projects when he was 6, and I never could, and I didn't, someone gave me some heroin, that's a very common story. And thinking about how that could have, if someone had access to a trusting relationship with anyone who was not, who was a provider. So I think that that's important. And, the process of stigmatization. There have been some interesting campaigns I've been thinking a lot about. Like there was one in New York City where we had a methadone and buprenorphine treatment campaign. There have been just campaigns. There was a very controversial and interesting campaign in South Dakota on meth that had a lot of people that were like, meth, I'm on it. And there were all these discussions being like, that old white guy's not on meth. And like, just like who uses like, like just having faces to, you know, like what is the role of these like kind of public health campaigns that are ostensibly meant to destigmatize substances, and like showing people. New York City had one that was like, I saved my brother's life with Narcan, and like featuring real people, you know, and I think those were really, and with a blurb of the story. And I think those are really meaningful ways that we can work against stigma, because it's so, and I'm also part of this group called Changing the Narrative. You can Google it. And it talks about the language and the rhetoric we use. You know, we're moving away from words like addict, abuse, you know, things, we're moving towards person-centered language, and all of those things really helps us decrease stigma in our general discourse and in our lives.
Wonderful. Thank you so much. I wish we were in person so we could give you a really big round of applause, but I guess I'll do it myself here. Thank you so much.
Thank you. Yeah, no problem. Thanks for having me.
Today. This was just a wonderful, really rich talk. Thanks.